sure, we haven't really communicated on a one-on-one basis the changes that have now happened to late phase. As you know, mid-phase last year we restructured and integrated, and all of you that have been doing the mid-phase students have been doing that whole nicely streamlined integrated project. Well, we did the same now for late phase, because late phase was still being done sort of separate little silo, students were confused. Yeah. So we tweaked it and we've tried to revise the study guide so that the students are presenting a uniform package when it comes to the patient presentation. So I'm just going to briefly orientate you as to what is expected for the learning outcome 1, which is what you are with. Okay. So the rubric, do you all have a rubric in front of you? It's not the latest, nicest one will be emailed to you that you've got it electronic for the sake. Late phase. You're busy with late phase now. Okay, not FASA. 5th or 6th year medical students, Tigerberg campus. All right, so basically what's happening now is at the start of their rotation, they must pick 3 patients. One patient is one presenting with a disability grant, one is a patient presenting with a chronic disease, and one is any other patient that's got a health condition leading to an impairment and functional fallout. So someone that can be easily plotted on the ICF. Okay, so they can decide what they want there, but it would be nice to guide them, a little, or just to check if what they've got is good. All right, so then they do the same. They've got to assess.
Can I quickly say this? This is for family medicine and rehab.
And community health. Everything is now, it's not like the student saying, what must I do for my one rehab patient? It's not. This is their patient presentations. This is it. It's not a separate family medicine, separate rehab. This is it.
And
okay.
Only present one of the 3.
Only present one of the 3. So the students are presenting 3 patients. Yeah. They've got to manage comprehensively. Your set's called comprehensive patient management in the study guide. They've got to write it up, follow up, go on a contextual visit, and then present the patient according to this rubric in week 5, and you choose one of them. All right. Just to let you know, the students are being very resistant on that, the fact that they have to go on 3 home visits, and some sites are trying to say just 1. I'm saying it's a contextual visit. You can only understand your context if you see the patient in the context. If the home visit is not relevant or safe, then they must go on a work visit, a school visit, wherever it's relevant for the context. If you could just speak them through that, because they are very scared now, apparently, for the home visits. Anyway, let's go through the rubric. So,
and they shouldn't go alone. They should go 2 or 3.
But now they're getting sites where the home-based carers are saying it's too dangerous to go, so don't. So obviously student safety is first. Of course. We're not going to, if they are burning buses in, say go do a bus visit. But I mean, they must understand the context of the patient and whatever is relevant for that patient. Home visit is not always necessarily the most relevant visit. Yes.
And where the students told me that they can't do home visits, I said, but then you will have bilateral information that you phoned a neighbour or a family member at home.
The home-based carer.
Yeah,
ask the home-based carer.
Yeah. So whoever, but then again, when they the thing is, I'm not going to. I think you have to rehab principles are all about fluid. You have to adapt. I'm not going to put it on paper saying it's okay. They've got to work as if they must go on a contextual visit for every single one. Yeah. We have to adapt if it's dangerous or impossible or impractical. When patients say no, so look, in America also they don't allow it.
I just think at the sites, if there's 3 students, there's 9 home visits to do, or 4 students, there's 12. So just when they draw up the timetables that they allow for adequate time, because when the timetables come out, there's maybe 1-2 hours for rehab, and then in that 2 hours they're going to meet with us and do their home visits. And
yeah, okay, this is, I don't know with late phase if you're getting those set time, but these students in late phase manage their own time.
Yeah, but each site creates a profile for them. They have to work at a clinic, do a
I don't know, no, maybe it's organised in Worcester, but I don't, in this side metro there is no, so the students are managing their own time. And we always say, do this should be, part of this thing is they've got to work out a cost, they've got to actually cost that patient, actually links with what Prof Notes was saying, that they actually did a public health aspect to cost the cost. So to make it cost effective, it should form part of a other group assessment or whatever. It mustn't just be a medical student going because their outcome is saying they must go. It must be relevant within the context. So they should be able to fit it in.
So they have nothing else to do besides these 3 patients?
These 2, then they've got 20 supervised consultations, but that's other outcomes.
And
with this outcome, this is all they've got.
And the community
Yes.
project.
Yeah.
Do you have the study guide?
Yes.
Yeah.
But we, like, for example,
new
when
one.
students come to us, they've got a timetable that they have to follow, like to get exposure to mobile clinics or something like that.
I think it's very nice for the students to have the program,
Yeah.
because some places don't have a program.
Yeah.
But what I found is that program is actually, it's quite easy to talk to the students about. Like if I have a look, which of those things, when you can do this. Because they've got so many weeks. Obviously they're going to do a home visit in the 1 week on this day, the next week on that day, or in the morning, or wherever. So they can still fit in all the other requirements on the other days. I actually found, if they just talk to the doctors, it's still possible.
Or just
Yeah.
go to the beach.
I think one of the other things is sometimes these timetables are the same for the past 10 years.
Yeah.
Yeah.
And
But-
just to
but
guide
there's
them.
totally new outcomes. It's
Yeah.
a new study
Yeah.
guide,
Yeah.
but nobody ever said, okay, let's sit down. These are the outcomes. How must our timetable look?
Yeah.
So
I think, can I just make a little logistic, can we go into the nitty gritty?
Yeah.
Heleen Sammons has got to go, and I want to get to the point of DG grant, so we can unpack that nitty gritty as we go. We're going to do it. Your call is important to me, okay? We don't get each other often, so.
In terms of the home visits and days, I'm always trying to put it back into what is the real situation clinically as us practicing. And if I really need something about X and it's too dangerous to go there, how do I get that information? So I think that's also problem solving.
Yeah.
So students can't always problem solve. Can't home visit. Okay.
And these are sickness, and unfortunately they're needing a lot of open wide spoon to swallow. But it's a product of our training, I don't know, but
Yes,
help-
but you could try and tell me.
Anyway, all right. But basically, part of the, I think for the sake, let's just get to this, but part of, in the past, you'll remember the disability grant was sort of separate. They had to get someone with the SASSA grant. Helen would mark it if they handed in. If they handed in, she would give feedback, but the feedback was coming while it wasn't a learning experience ultimately because they weren't taking on that feedback because the rotation was finished. So we decided if we include a patient presenting with a disability grant as one of the patients, they should have ICF issues because if you're not able to work. Yeah. So now part of that is so that disability grant has now been integrated into that family, into that presentation. In week 3, just so that you know, they have the option to email that disability grant to Helen so that she can give the formative feedback, the specialist feedback. So far she's received none, by the way, from our students. So you're going to be working with Virgin Territory on your assessments at the end of people, students that haven't sought professional advice on how to complete it. But every student is going to hand in, like they do the genogram, they're going to hand in their disability grant at the presentation, even if that patient's not the one that you're choosing to present. Okay? But you as a panel are going to mark that disability grant for us. So that it's done there and then, added, and as we've given it a stronger weighting than what it used to have. It used to be like 1%, so they thought, if I don't do it, what's the point? So it's going to have a bigger, you'll see we've given it a weight of 4 on that. So even if it is a chronic or a other, the disability grant will be marked and added. And hopefully you will have walked a journey with them as facilitators with that patient too, because it would have been one of the 3 that you're going to. So I'm quickly going to hand over to Heleen just to speak to us to what are the things we look at with the disability grant, what are the right ways to complete it, because, so that we give a fair mark at the end of the day. I'd also suggest if you've got any questions throughout the rotation linked to the disability grants to contact Heleen. And it might be room for capacity development in our areas that we have a workshop that more people need training on.
How do we contact Heleen?
She is in our facilitator contact, but she's Helen.Sammons at westerncape.gov.co. capital H dot
Sorry,
capital
I might
S.
have missed it. So even if they're presenting the functional fallout patient, we still have to mark the DG.
Yeah.
Okay.
Yeah, so that's,
Second cell numbers 084 250 1328. Right, not very good on emails.
but we will go, I'm gonna tape Helen's talk now also, and then we're gonna put that on our iPad account as a YouTube clip later, so that, or do we all get some? But anyway, so that you've got it, that you can re-look at it. And the students have also got a podcast that they listen to on this, that Helen has done previously. But let's hand over to you, and then we will answer any questions and logistics and nitty-gritties afterwards. I'm going to sit next to you.
I must say I am not majorly prepared for this, but I must say that the podcast that I did for the students actually really came out well. And that basically covers everything. I listened to it a couple of times afterwards, and they just had brilliant cases and everything. So that I'm quite happy is quite comprehensive in terms of how to discuss the DGs with the patients. Okay. No, first of all, just in terms of patient selection, it's one thing that the students are often very concerned about. You get two extremes. You get the no-brainer, the tetraplegic, sanitary education, who was a labourer, who is 45. He's obviously going to get a permanent DG. Okay. Then you get the patient who doesn't qualify. And I often say to the students, the patient that doesn't qualify actually requires more thought process. And I prefer it if they have that more difficult, if a patient doesn't qualify. Because it makes them think a little bit about the back aches, and even, let's say the other cases, the chronic hypertensives. It's really good food for thought because it makes you interrogate the ICF and why are you doing certain things. And the whole rationale about whether a patient qualifies yes or no is obviously looking at the patient's bigger picture. And I'm not going to go into that much detail per se, because please listen to the podcast. It is, like I said, I'm really chuffed with that one. It did come out well, thank goodness. Okay. But just in terms of marking the disability grant, there are certain things that, in terms of being able to communicate on a piece of paper, social services gets a form. And based on that, number one, it must make sense. And I tell the students, give your disability grant form to somebody else to have a look at. And if they read through it, does it make sense, yes or no? But I don't think they ever do that. Sometimes also I'm surprisingly disappointed that they do terribly on the disability grant, even though they've had all the information. And I don't know why it is. And it's no different from when I was having contact sessions with him directly and when they listen to the podcasts. There are still some that do brilliantly, they get 70%. And there's others that fail. And believe me, they fail this because there are basic, simple things that they don't do. Okay. So, what I expect them to do, and I've given you the marking schedule that we have always used up to date. And as we basically, this is just my scribblings, which I did for my own rubric. And then you can pull that into that last section to be able to objectively assess.
Then basically at the end, this must be translated into, was it a poor, adequate, or good? That scale of 1 to 9. So you can use this as a guideline, and then you'll get an idea, was this a good, adequate, or a poor? And then you give your score out of 9 at the bottom now.
Basically, these 8 items that are listed on this assessment schedule is based on problem areas that we experienced clinically when we worked a lot with disability grants in the good old days. But what were the problem areas that doctors were not doing properly? And that's why we also decided to include the training, and that's why these are down on the list. And also it's almost stepwise the things that they need to put down in order to make a decision. So if they've got each one of those things down, it should 1 + 1 + 1 = 3. Okay. So the first thing that they need to do is have the administrative requirements. So they need to mark off, did they identify the patient? At the bottom of the form, at the end of the form, it says here, I hereby declare that I have examined the identified client. So the students also need to have the sense of responsibility that they have ID'd the patient and understand what does it mean to actually ID and look at an ID and make sure the name is right. And the whole thing that sometimes the ID and the patient sticker is not the same, and those discrepancies. So that comes
And I'd
out.
like to add it there, it was a patient's just been declined a disability grant because the patient's sticker was wrong. So the name was wrong according to the ID. So therefore they must write it
They
down.
must write it and they must not put stickers on. Social services is going to, that's the other thing, is how to fill in the form so that it doesn't come back so the patient doesn't come and knock on your door again. The argument the students often say, oh yeah, but there's a DG doctor. But DG doctors are not going to be there forever. The idea is they're phasing them out. The whole idea of managing the patient comprehensively, including his work and occupational aspects, makes a lot of logical sense. So I think and also you're not always going to have DG doctors wherever you go. They're going to be in acute hospitals and whatever. Okay. So they've identified the patient, they've put in the ID number. Just note that there's actually one block too short, so the last digit goes into that little space between the last block and the male there, okay. Surname, maiden name is obviously not critical. The patient's name. They should actually put in the local office because you will know which area that the student is working in, but that also indicates in terms of what resources are available, because managing a patient in Vredendal is very different to managing a patient in the centre of Cape Town. Okay. The form that I've given you now is probably one of the slightly older ones, and there are variations in the form, but this is basically what they're working from at the moment, but the principles still apply. Education, I always say age, education, and past work history are three things that have to appear on the form, apart from the diagnosis, okay? But from an occupational side, no, OT's here, so you bear with me and correct me. Age is there because of the ID. Education, it needs to be on the form, and if they're using an old form somewhere, they need to indicate the past education of the patient, and they need to indicate the work history of the patient.
They're using this form, so it's not.
Which I normally put under presenting complaints because, which brings us to presenting complaints. The presenting complaints is not the diagnosis. The diagnosis comes later on the form. Because the students also need to learn to think stepwise. Okay, you take a history, you examine the patient, you do your special investigations, you come up with a diagnosis, and then you make an assessment. And you need to follow through those steps. So the complaints needs to relate to impairment activities and participation. So what are their complaints? And obviously then you need a history, a timeline, you need dates, you need what's their work history, what's their context, okay?
But the important is not just biomedical, it's also the functioning of the participation.
Exactly.
You think about those domains in the ICF, not just airy-fairy activities.
And on the tape also you'll hear, I often say to the students, or I often ask the patients, but why can't you work? No, because the auntie next door gets a disability grant. I said, okay, let's go through this one. But no, if I can only work for 2 hours and my chest closes up or my back gets really sore and I can work for 3 days, but on the 4th day I can't get out of bed, that's the kind of thing that we're looking for. So it's functional stuff, okay? Is the patient getting treatment? Yes, what and where? I actually quite like it. It's got medical, surgical, and rehabilitative treatment. So if it's medical, then they will have the medication under A, B, C, D, and ideally they should write it out in full. They are 6-year medical students. It's like a script, almost, okay? If there's lots of meds, I mean, some of our patients are 18, 12 meds, then I don't mind if they group them like anti-diabetic, the ARVs, the whatever, but there should be some sort of intelligence to the medication, not just pain tablets, okay? DB meds, okay? There seems to be some intelligence to that. And if it's surgical and rehabilitative, what social service also looks at is, okay, fine, you've got a patient with this symptom complex and this diagnosis, but what has been done about this patient? Where are we going to? And that's what I talk about in terms of this whole thing needs to make a story. Okay, you've got Mr. X, this is his age, education, and his work history. This is his symptom complex and his diagnosis. We've done all this treatment and everything, and you know what, he's an absolute hopeless case. So therefore, yes, permanent disability, I totally understand. But if, obviously, a different case scenario and there's options and there should be work rehab involved and then that must come out in the form. So it's not writing a story, but it's being able to communicate on a form. And I also tell them that they're not going to only fill in DGs. They're going to fill in insurance medicals, other pillar forms, lots of forms that you need to communicate on to the patients better. WCA forms, exactly. So they also mustn't get miffed because, oh no, we're never going to do DGs. As private practitioners, they can earn lots of money by filling in insurance medical forms. Okay, so they better learn to do them properly. Okay, so that's the, all right, I'm jumping around a bit. That's part of the administrative requirements. Okay, part one. Number 2 was the patient's complaints. Note that it says that the patient's perceived impact on the activities and participations, because that's what it is at this stage. It's not the objective thing. From the history, it's the patient's perspective. Okay, describe the current treatment plan, which I've just done now. Then the next part, D, that is the physical assessment. Okay, please note they must please ring of all those 1, 2, 3, 4, 5s. In each line, they must ring one of the 1, 2, 3, 4s and 5s. They must not leave blanks. If you fill in a form and you leave blanks, they are open to fraud. Okay, so they must learn to fill in everything. So if there's no impairment, they must do all the 5s, and where there's a problem, they need to judge, and there is no scale, it's on their opinion. Okay, then under elaborate needs to be the relevant medical examination. Okay. And it's not a rehashing of the symptoms. They need to, because you've taken a history, this is the patient's perceived situation, so you examine to substantiate. So how does the examination, I think I put there, the physical assessment supports or refutes the complaints. So that is the purpose of the examination in this case. All right. Okay, then it goes on to the next page. There's results. If there's any special investigations that are relevant, then comes the diagnosis. Okay. Now we are on item number 5. The outcome level is supported by the diagnosis and use of assisted devices. So line number 5 would be the diagnosis and is the activity limitation and the benefits of assisted devices. So that's looking at the diagnosis, looking at the functional impairment, which again needs to make sense as to whether this patient can work, yes or no. All right. That line there about comments on referral form of clinical findings, the SASA says that is like if, say, the specialist refer the patient to the day hospital for ongoing management, that there needs to be some correlation between what they find at the day hospital versus a specialist. But I normally don't worry about that line, so don't worry too much about that. All right, and the further administrative requirements is that the patient must sign, or they must have a thumbprint. Sometimes the students have seen the patient and then they fill in the form afterwards, so the patient's gone. But I tell them it's okay as long as you indicate to me that you know that the patient's signature is going. So sometimes they draw thumbprints, or you could see they make a nice little signature or whatever. But as long as they understand what needs to go onto the form. Okay. Let me just finish the administrative stuff. Under F, the declaration, they must write their name. As a professional, I'm not going to write my first name in. I'm funny that way, but I write Dr. H.E. Sammons. That's my professional name. My contact details is my office phone number. I don't put my personal cell phone number in. I just feel if it's a state form, that's the professionalism. If I was in private practice and that was my cell phone for private use, then I would put my cell phone in. Okay, so it's also getting that professionalism across. Instead of MP number, they must put their student number in. So, yeah, if they've put in their cell number, I actually mark it down because I've told them don't put your personal cell number in. Okay. MP number must be the student number, they must sign it, they must date it, and then either get the facility stamp, or they must draw a stamp, or they must write it must be stamped, but do they know it must be stamped? Because if it's not stamped, the patient's going to come back to them. Okay. All right, so that's the end of the administrative.
Can I just ask on this, if they fill it in but then complete it but then ask the doctors to sign it, is it not? They've got to
it's the students, and it says here, for training purposes only, cancelled,
okay.
It's not going anywhere. Okay, and I see that, they get the doctors at the day hospital to sign it.
But I sometimes find that the doctors in some of the small hospitals actually let them do it. So what I'm asking is, if The doctor should actually fill it in.
Yeah, they're not, students are not allowed to complete them in the real bookie, okay? But this is their practice example as a student, so it's their work, not their
I
supervisor's.
think for the record, you're only allowed to, in your Cosmo year, start, no, but the SASA says in year 2 of Cosmo or something that they're allowed to.
Cosmo is 1 year, internship is 2 years.
So then it was internship year. In their intern year, they may not in their first year of Cosmo fill out these internship. They may not fill out them, but the year after that, they're legally allowed to complete these
Because
forms.
there was also a question about a workman's compensation form where the doctor actually asked the student to complete the form.
Well, then that doctor's got to make very sure he's
You
checked
must
absolutely.
co-sign,
Yeah.
Because the doctor will be responsible.
Yeah.
The student cannot sign.
The student cannot sign anything. It's the same like scripts in the hospital.
Yeah.
Where students used to write them up, but the
Yeah.
doctor used to co-sign them.
Yeah.
I just want to confirm.
Yeah.
Yeah, I mean, with WHA, usually it's just 3 lines. I mean,
Yeah, but you still need to write in there your qualifications.
Yeah, that
I-
obviously is the doctor.
So MA, and then you write there a medical practitioner. So if you write there your student, they're going to check it out.
Okay.
And WCA is so fussy. Yeah, it's
All fussy.
another ball game. Yeah, they are. And yeah, that's the other thing is, okay, I don't mind too much if the students make corrections, but I know for ourselves, if we make any corrections, new form, you've got to start writing from scratch again. So, yeah. Okay, let's go back.
Even you can't just initial them.
They don't accept it.
Okay.
Yeah, there has been so much fraud.
Yeah.
They
And they
understand
don't
so
allow
strict.
civics or anything
No.
like that.
No.
Because of fraud.
No. Okay. All right. So we are now on line number 6 and 7, and that is this block, which on the actual form I think is in red. Okay. Just make sure that the students' copies of their form, sometimes they're so dark that you can't read what's on them.
got
This
good
is
copies.
quite a nice copy at the moment. Freya's got good copies.
Yeah, you can go.
Okay. So they say the recommendations demonstrate clinical reasoning. So basically, they have to write an ID number again, the diagnosis, the complications. Okay, and that's where the reasoning comes in. So, okay, the patient might have complications. Is the patient on optimum treatment? Yes. If they're on optimum treatment, would they actually be referred for further treatment? Usually no. So they say just check that, because often it's just check yes, 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 yes. And then compliance. They must also interrogate compliance, whether it is reasonable or not, because you get some patients who are non-compliant so that they can get their DG. Some patients who have got absolutely no insight, no support, and you know what? It's actually quite understandable that they're non-compliant. So you need to interrogate why. There's some patients who, I mean, I know for myself, this is on record, I was given a physio program. It hurt and it didn't help. I didn't do it.
Yeah.
So, side effects of medication. So don't just say, patient's non-compliant. Interrogate the non-compliance, okay? And then has the patient reached maximum medical improvement? And I think that's the important question, because if they haven't, what is the prognosis? And that will inform whether it's they are temporary or permanent, or whether there's further interventions or whatever. Okay. Then how severe is the impairment? Again, it's their judgment. And does it affect the ability to enter open labour market? Okay, so that's all under recommendations. Then the certification is whether they are disabled, yes or no, whether they get a disability grant, yes or no, temporary or permanent. The newer, just out of this is the form that they're using, but on the newer forms, permanent now is apparently 3 years, and then you say with or without review. But apparently they've reduced. I haven't heard that. Like
So it's
a
gone
week
from
ago.
5 to 3.
Permanent is now apparently 3 years.
Okay.
So if the students question that, whatever, you can just do it. Okay.
And temporary, 6 months.
Temporary, you can mark whether it's between 6 and 12 months.
Okay.
You can make that choice. And that should have some clinical reasoning. And so if you listen to the audio tape, it's nice as we go through a few case examples. So if the patient, especially a neurological condition, the patient is clearly disabled, and it's going to take 6 months to sort him out and whatever, then yeah, give him a 6 months DG. But if the person's had a stroke 3 years ago and they're not able to work, why are you still giving him temporary disability grant repeatedly? You know. So, but if the condition should improve within 6 months and the person is able to return to work within 6 months, then they shouldn't be getting a disability grant.
Then we refer them to unemployment fund.
Yeah, then you've got the options. There's social relief of distress, which is if the patient actually is disabled, but they won't be disabled for 6 months. And a typical example there is a fracture. Like fracture is going to heal in 3 months. And then grant in aid is if the person needs personal assistance. So they need the full-time assistance of a carer. So that's either from a psychiatric point of view, supervision, that kind of thing, or physical, that the person is at risk. They can't be on their own all day. So the idea is that if a patient can be up and sitting in a wheelchair all day long, they can access food and toileting and things like that. They can actually be independent and don't need a carer. Okay. But they need somebody to turn them, to feed them, to empty the catheter bag. They need full-time supervision, whatever.
If they have dementia.
Yes, if from a cognitive point of view that they're unsafe to be on their own, they're going to wander, they're going to be a risk for themselves, yes, then they need full-time supervision.
Sorry,
Okay. Yeah?
The grant in aid, is it, this is now not for the person, for the disabled person. Why is it on this film? Doesn't
The
the
grant
carer have to apply for it?
The grant in aid money belongs to the patient. Okay, I always laugh because the carer comes in and says, "Dis hier vir my grant." I say, "It's nie vir jou grant, it's vir sy grant." Okay, it's the patient's grant because it could be he could pay that money to anybody he likes. Okay, and this month it might be this person, another month it could be somebody
In
else.
addition to the grant.
It's in addition to their grant.
And how should one go about if somebody's already gotten a DG but the grant and aid was never ticked?
You have to fill in a whole new form.
A whole new form.
There's separate books. There's also the book for the child grant. I think there's two different books, but I know there's a different book completely for the child grant. But I know if we want to apply for a grant in aid, we have to complete the whole thing because you have to prove that the person is disabled to such an extent. So even like with old age pensions, they get grant in aid, and you actually have to complete this form so they can get grant in aid. Yeah.
And is that paid then on top of the disability?
It's in addition. I can't remember the figures offhand now. Yeah. There's the last thing, which is something that we added, was note at the end of the form the need and role of an occupational therapist in the vocational management of the patient. Because I tell the students, when you think work, you have to think OT. Okay. Now there is no place here. They can, under treatment, under rehab, they could write there they've used an OT or refer to an OT for ADLs and stuff like that. This refers to vocational rehab. So if they've put in something there about OT, I might give them a 2 or a 3 in terms of the ADL, but what I'm looking for is that they've thought, do I need an OT's input in terms of deciding whether the person qualifies for a disability grant, yes or no? And is there any need for any further vocational rehab? A young patient with a good education, they really should be thinking OT. Yeah, there's certain scenarios where you really should think OT. And I want them to think of that, and I'm sure you would too.
So, yeah, because I've got one of those coming out in the exam, so must they put it in here or must they put it, where must I write it?
They can write it either under the rehab treatment, or they can put here refer for further treatment, or else I tell them, just as I've done on here, role of OT, they can just add it on underneath. It's sort of an extra thing, but they've got to think of OT. I mean, honestly.
Should be in the next form, the new update.
It should be,
Yeah.
yeah. I just think it's so critical, and the patients are dipping out on so much if people aren't thinking of OTs. Yeah. Are there any questions? Does it make sense? I've sort of given, on this marking schedule, I've scribbled little things. I tend to mark them quite strictly because I actually think it's fairly straightforward to fill in a DG form. It's not rocket science. Administratively, you must just fill in all the blockies. So if you don't, I just progressively deduct. I actually start at 7. I don't score 10 because 7 to me is an average mark from a vastly point of view. But 70% is you looking towards cum. And I mean, if you just do the basics, So yes, it's very difficult to score extra points on administrative stuff, but you should actually put in all the components. So basically I give 7s. If they've described the patient well, they've given an appropriate, reasonable examination, sort of basic, that, this makes sense, okay, this is cool. If they've gone over and above and they're really explicit and you can see they really understand this patient, they put in extra, I'll give them 16s and whatever higher according to this scoring.
Obviously, if we look, I think so. What Helen is saying is she starts with the low good with each patient, and then walks down to okay, it was adequate or poor, or if it's really good, you go. So you're going to take. I think it helps to have the rubric in front of you as to how she got there.
Yeah.
We did bullet them on the rubric, but it helps to also see where you're seeing more emphasis is on. You put more emphasis on those 2 factors. So if they've really not done well there, it should grab. So in the end, you're giving an overall impression mark out of 9, bearing into account that they should have acted up on feedback that Helen has given them after week 3. And if they haven't given it to Helen, and I think they must be nailed there too, that they haven't utilized this opportunity, and it says something about their attitude towards the management of the patient too.
But if they don't make it, then with the assessment, if the DG form is not up to scratch and they don't, we say it's not. Good.
Then you give them
I understand that, but I want to know if we give them then like a rewrite and tell them to.
Well, look, in essence, they've in essence they've been given that opportunity. Helen would have told them in week 3 it's not up to scratch.
I will write
So this is their final exam now.
That's missing. Explain here. Where's the work history? I will write in those specific comments.
Do we give them feedback in the exam or not?
Well, it's like any.
Because I think most of us mark this afterwards because it takes time, so they don't see it again after we're done.
That's why the formative feedback is so important.
Yeah. So if something really stands out to you that you can see is a no-brainer, listen here, this was lacking, then you can say that you haven't necessarily given the final mark. But as you're doing throughout your assessment, you are giving a form of feedback as to how they are.
But we probably wouldn't let them sit in front of us while we mark this because it takes extra time.
Yeah, but okay.
So they're already gone by the time we look at it.
Yeah.
So do they see this paper again afterwards? Probably not, eh?
That's why we actually introduced this middle of the block involving myself, because I was marking them at the end of the block and they never got any feedback, so which was actually a pity.
So what you're actually saying is that week 3 you should say, have you seen your DG grants?
And we give them this one, but they're going to have to, they can scan from Gerga because Helen needs to get it electronically. We can't courier it to her. We don't have the funds to courier it. So they must get it to her. So if they a good scan, and they can chop their thing in half.
Yeah, they just scan half.
And they've got scanning facilities here at Gerga.
Is it possible to have someone actually do this on a easily to complete a digital format?
I don't actually want them to do that because this is how it comes in the book. They must do it in real life.
I was just thinking of getting it, 2 people.
I've had them scanned to me before. Freda doesn't always get them to me physically to mark, and she scans and mails them. And for one student to scan 2 pages,
that's placed further away.
All the late phase students, because this is a late phase assignment, they've got access to it. So we also
and again, it's problem solving.
Yes.
Then it's not a
You
plan.
can scan
I mean,
phone cards.
Yeah.
Just have an app.
Yeah.
Take a